And I would like to pass the baton to Jackson, who I've had the great pleasure of working with on a statewide grant that's funded by state Medicaid over the last, 5 months or so. But he's a star, and he's a global authority on hypertension. He's taken a senior role, either principal investigator, co-principal investigator, on many national and international clinical trials, focusing on African Americans who have hypertension, with the notion that they want to accelerate adoption and spread of good practices. He was recipient of one of the most highly recognized, coveted prizes at this year's commencement of Case Western Reserve University, the Avorka Prize, and I welcome you to make some comments.
First of all, Randy, congratulations to you for your many awards, and certainly the most recent one. My commentary is to deal with the progress that has been made by Better Health Partnership in hypertension. Hypertension and diabetes are leading to cardiovascular disease are especially common and devastating in minority populations, in populations with limited financial resources, and especially in African American populations. In African Americans, hypertension occurs at an earlier age. It is about 30% more common in African Americans compared to whites. It is less well controlled in African Americans, and average overall blood pressures running about 2 to 4 millimeters of mercury higher than in whites. It is responsible for 30% higher rates of stroke, 80% higher rates of fatal strokes, and it is the leading cause of about a 50% higher rate of heart disease and mortality, and up to 20 times higher rates of kidney failure compared to non-Hispanic whites. And in fact, 30% of black males, 20% of black females will die as a direct result of hypertension. It is also worth noting that while hypertension is less common in Hispanic Americans, that in fact Hispanics have lower or higher rates of poor blood pressure control. And in fact, the hypertensive control rates in Hispanics in the U.S. are even lower than in African Americans. So it is in that context that we look at the data presented by Dr. Siebel from the Better Health Partnership. He and his group have shown that working with practices in developing and implementing best practices and showing these practices their data alongside the data from other similar practices results in dramatic improvements in the quality of measures known to be associated with morbidity, with risk of morbidity and mortality. And at least as importantly, these increases in quality measures can be shown not only overall, but with greatest gains in improvement of care seen in black and Hispanic compared to non-Hispanic white patients, in lower income compared to higher income patients, and Medicaid and even the uninsured compared to those with commercial insurance. And these improvements have essentially eliminated these population health disparities in quality metrics in practices for pneumonia immunization and diabetes care, and they've shown a narrowing of the gap in blood pressure control. So I'm pleased to have recently started a project with Dr. Sherry Bolin of the Better Health Partnership, and along with Randy Siebel, to extend their work on blood pressure control to Medicaid patients throughout the state of Ohio. It was in 1985, that's 32 years ago, that the Health and Human Services Secretary Margaret Heckler published a task force report on black and minority health, describing the gap in health outcomes between black and white populations. This report was the start of a campaign establishing a national mandate for the study of health disparities. It documented that in black patients, that if black patients had the same health outcomes as in whites, 58,000 more would live each year. It defined 6 causes of death that accounted for 80% of the excess deaths that would not have occurred if the black community had the same mortality rates for those disorders similar to those in whites. Now, shamefully, 10% of these excess deaths were due to excesses in infant mortality. But half of the remaining causes of excess mortality are due to cardiovascular disease and diabetes, which have been the major focus of the Better Health Partnership. So these data that we've seen today, presented today, clearly demonstrate that we can, in fact, narrow the gap in at least 2 of the major causes of morbidity and mortality. It has been 32 years over which we have conducted extensive studies on the mechanisms and epidemiology of health disparities. These studies have produced, studies on the mechanisms and epidemiology of health disparities have produced important data. But the 50 to 60,000 excess deaths each year have continued with little difference in the size of this gap. And this is the first year that the gap in life expectancy between blacks and whites has significantly decreased. Thus, it is well past time to refocus our efforts away from simply studying its causes and natural history of population differences in health outcomes. After 32 years, it is well past time to emphasize studies that focus on interventions to reduce health disparities rather than simply continuing to focus on those directed at studying their cause. Certainly for hypertension, we now know how to treat to minimize its risk, even in black populations. We have shown this in many large studies, and it is on this basis that the significance of efforts undertaken and being undertaken by Better Health Partnerships on interventions to reduce health disparities must be appreciated. Thus, the data presented here today are impressive in showing that the gap in disparities of quality of health care can be reduced with greater improvements in the care of populations most at risk. In most populations worldwide, hypertension presents the major cause of morbidity and mortality. Better Health Partnership's next project to examine strategies to improve hypertension care in Medicaid populations will be one worth watching. So, thank you. And congratulations.